We think there's an increasing number of individuals who self-identify as gender non-conforming, including those who identify as transgender individuals. As we discussed, there's a significant confusion in the healthcare community as to how to approach and care for gender non-conforming and transgender individuals, resulting in what we believe is suboptimal clinical care, bias, prejudice, and even stereotyping. And we think windows of opportunity may exist where there is a disconnect between the physiologic development of the brain and genitals such that natal sex actually differs from gender identity. My name's Dr. Biff F. Palmer, and I'm a professor of internal medicine at University of Texas Southwestern Medical Center.
My name is Dr. Deborah Clegg. I'm the Associate Dean for Research in the College of Nursing and Health Professionals at Drexel University in Philadelphia, Pennsylvania.
Well, thank you for joining us. We're here to discuss our recently published article, A Universally Accepted Definition of Gender Will Positively Impact Societal Understanding, Acceptances, and Appropriateness of Health Care. And so I'd like to ask my colleague to comment on a couple of questions. One, is there clinician-imposed gender bias which impacts health care?
Thank you, Dr. Palmer, for that question. I think indeed there is. I think that oftentimes clinicians, whenever they see, for example, a woman present to the ER with chest pains, they may think that that may or may not be associated with cardiovascular disease. And so just in looking at male versus female, there are very, very strong intrinsic differences with respect to how clinicians approach these individuals. Now, if you impose gender, or if you impose a gender that's non-binary, again, I have a feeling that there is a strong clinician bias. Sometimes they probably don't even know how to approach the individual appropriately. And I think that this then causes the individual who is gender non-binary to be afraid of the healthcare system. They're not certain when they actually arrive in an emergency room or at a healthcare clinic how they will be addressed. And even names are associated with bias, even when the nurse is calling the individual into the healthcare room, or even as the physician is looking at the overall chart prior to even seeing the individual, a name may automatically trigger a bias with respect to sex or gender. And this may then preclude or predetermine how the overall visit will be taken into consideration. And I think these are some really important aspects that are underappreciated, but I think this leads to why gender non-conforming individuals feel so marginalized with respect to the healthcare environment, and they have fears associated with this.
Thank you. What can we learn about marginalized societies, particularly in this time of racial unrest? And are there lessons that we should take away from what is currently happening in the United States?
Thank you, Dr. Palmer, for that question as well. I really think that this is a time when marginalized communities and marginalized individuals are at the forefront. We're seeing racial injustices. We know that there's racial bias with respect to healthcare. And I think that we should be able to also begin to appreciate that there's also gender biases with respect to healthcare. I think what we're really seeing is that when marginalized people are not treated appropriately or fairly, there's a public outcry, and that we all need to enhance our sensitivities about not only race, but also gender, and how we approach these individuals with respect to healthcare or with respect to society. So I think this is a really, really important time for us to focus on this. There's so much that we don't know with respect to race or gender and how it actually influences overall health. And we need to take this time where there's a momentum building about the importance of looking at these marginalized societies and understanding how we can care for them. I will also emphasize that the fact that marginalized societies are afraid of the healthcare system. They don't typically go to the doctor because, again, they're afraid of how they may be perceived. And I think that that's really having an impact on what we're seeing right now. They're afraid to go to the police. They're afraid for so many different aspects of their lives. And so I think we need to start taking down these barriers and begin to really understand that all of us are created equal and that we need to appreciate that.
One of the things we've learned about this pandemic is that there are certain comorbidities that make one more susceptible to the disease. do we have any knowledge about sex and gender and how it influences the COVID-19 infection, and what have we learned?
So thank you for that question. I think that this is absolutely fascinating. And what I'm really excited about is that for COVID-19, we're actually seeing data being accumulated that are gender or sex specific. And let me emphasize this. What we actually know right now is that when we're looking at the demographics between males or females, and that would be a sex-related demographic, we know that females are less likely to die from COVID-19. And there are data now to suggest that this has to do with female immunity, it has to do with the X sex chromosome, and as well as it actually has to do with sex hormones, specifically estrogens. But at the same time, when we look at the demographics, what we find is that individuals who are feminine or who have roles within society where their gender is influenced as far as their types of jobs that they are engaged in, whether they're healthcare workers, the nurses, or whether they happen to be flight attendants, people who have a female gender type role within society, they tend to be the frontline workers. And therefore, these individuals are tending to have more COVID exposure. So again, if you look at the way that sex and gender separate, with even just looking at COVID, we see a sex-based difference on mortality associated with COVID, but we see no differences with respect to genders, with respect to the number of individuals who present with the disease, saying that the gender of male or female are actually present with the same number of overall cases of COVID, but the sex differences with respect to mortality are quite profound. So this is an interesting case where it's one of the first cases where I actually have seen that society is actually accumulating data that not only is specific for sex, but also specific for gender. And it's even more exciting was when we're starting to accumulate some of the data with respect to the transgender individuals. There's now data to suggest that cisgender women, as well as transgender women, have less COVID overall fatalities. And this is really important because it's beginning to elucidate that there's probably a combination of sex chromosome as well as sex hormone that actually reduces the overall fatality with respect to COVID. And so I think that this is a prime opportunity where, again, we can dissociate the concept of sex versus gender and look at diseases such as COVID and begin to really highlight the importance of understanding those different diseases.
Well, thank you very much for answering those questions. I hope the readers will realize that we cover some very timely topics in this manuscript. Dr. Clegg, is there any take-home message that you would like to emphasize that's highlighted in the article?
Thank you. I really would like to, because I think this is an important read for all healthcare workers. We really cover the information or lack thereof of the scientific understanding of the basis behind gender. We don't know where science and gender intersect, and we really try to bring this information out with respect to our manuscript. Additionally, we try to add a little bit of scientific basis for understanding when and where gender might arise during development and how this could be influenced with societal exposure, such as to bisphenol A or to xenoestrogens, which may then allow the individual to have a disconnect between their natal sex and their gender identity. We also highlight that some of these individuals who identify themselves as gender non-binary actually identify themselves as that even at age 2 or 3, way before societal imprinting ever occurs. So what we're really trying to emphasize in this article is that it's important to understand that there are individuals, an increasing number of individuals who are identifying themselves as gender non-binary. Additionally, as healthcare workers, we have to appreciate that when these individuals identify as a gender non-binary, they're afraid of the healthcare system, and we need to really learn much more about how we can make them comfortable with respect to overall healthcare. And we believe that if we understand the origins of gender identity and add some science and backbone to this, it will begin to sort of remove some of those barriers, and hopefully then all individuals will be created equal and be treated as individuals when they are coming into the healthcare system. So thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.